Hi, welcome to Straight Talk. We've always put our emphasis on trying to educate the public about the opioid epidemic. We've done a series of shows trying to get you, the public, to understand the magnitude of the problem, but also the solutions to the problem. And today we're going to talk about something that I don't think too many people talk about, which is the role of the physician in drug treatment and the whole drug epidemic itself. And we have a real expert with us, Dr. Alfred Forrester, who has been in this field for a long time and has worked in the field of addictions and is currently the medical director of the Maryland Addiction Recovery Center, and a real pioneer and a real expert in this field. And we're so happy to have you, Dr. Forrester.
Thank you.
Thanks for being with us. You know, we try to let the public know the newest things going on and why things happen. And when we talk about the physician in drug addiction, what is the role? What is the role of the physician when we talk about drug treatment and drug addiction?
Well, for one, I think it's very important to realize that many of the individuals coming in with substance use disorders have other psychiatric conditions at the same time. And so it's really very important that patients have a very decent and thorough assessment so that we know exactly what sort of psychiatric conditions we're dealing with, as well as their substance abuse conditions. And the role of the physician is not only to be the head of that team who will be assessing patients, but for those individuals who may need to be on psychiatric medication or may need to be on other types of medicines dealing with other physical conditions, it's very important that the physician is going to be there to be able to prescribe whatever medications that patient may need.
And so when someone comes into the program that you're medical director of, do you do like an evaluation of all the patients that come in and the clients that come in?
Yes.
Is that standard?
Yeah, that is standard. What will happen is that the individual may be seen by a member of the admissions department, and a very thorough history will be taken, although actually we receive information from referring institutions even prior to the patient arriving. The admissions person will do the intake evaluation, and probably within the first 2 to 3 days, each of the patients who have been taken into our program will be seen by one of the psychiatrists in our program to do a formal psychiatric assessment.
And when you do that, and again, you've been in this field for quite a while.
Yes.
And you've been doing these for quite a while. What are you seeing these days, especially with this opiate epidemic and the other crazy drugs that seem to be out there, a lot of these synthetic drugs? What are you seeing when you see these patients now? Are you seeing a lot of like co-occurring disorders? Are you seeing, you know, the old days you used to have just you were an alcoholic and that was it,
right,
or you were an addict and that was it. But now we look at mental illness and mental health as part of it. What are you seeing? What's your evaluation?
I think many of our colleagues and ourselves could estimate that between 60 and 75% of individuals coming in with a substance use disorder have some other sort of co-occurring psychiatric disorder. That may be major depression, it may be one of the anxiety disorders, it may be attention deficit disorder. And clearly, if we're able to take history carefully enough, or if the patient is able to provide information that is credible enough, we can sometimes track the course of how this illness has progressed, such that these are individuals who may have had a first depression at the age of 12, or maybe started having anxiety symptoms at the age of 8 or 9, and they find little by little that some of the substances that are out in the world can treat these conditions, can treat their symptoms. And so they may start using substances at the age of 12 or 13 or 14. By the time they get to us, they may or may not have ever been treated for their psychiatric condition, but they've been treating themselves using a whole variety of substances.
That's a great way to put it. That's really a good clarification, because we always talk about what came first. You know, was it the addiction? Was it the mental illness? Was it, and what you're saying is, you know, one is complementing the other.
Right.
But again, happening usually in an early age, which means parents, if they were being aware of what's going on with their child at an early age, might be able to really do some early prevention.
Yes, that's true. Actually, some of our patients will say that they would go to parents and say, you know, I'm not feeling well. They may not use the language of I'm feeling depressed or I'm having panic attacks, but they may be able to explain in their own words what they're experiencing. And many times parents will just say, well, you know, just live with it, or it'll go away on its own, et cetera, et cetera. But many of these conditions don't go away on their own, and so our individual patients will find ways to deal with these symptoms to make themselves feel better.
Which, you know, we talk about prevention. If you really want to get involved early, like you said, you have to pay attention to what your kids are going through.
Right.
If they're not able to read, comprehend, maybe they have attention deficit problems. You know, there's a lot of things that can happen, but parents have to be aware early before they start, as you say, self-medicate themselves. And then when they get older teens, and then they have issues like, you know, relationships and sexuality and school pressure and sports, does that mount on a child?
Well, the pressure mounts, but they may never make it that far. They may get so entangled in the use of substances that they really miss out. We find that a lot of the individuals coming into programs in their 20s and 30s are really behaving very much like early adolescents because they have not matured the way that other individuals who are not using substances during those early years have matured.
Awesome. We're talking with Dr. Alfred Forrester, who's medical director of the Maryland Addiction Recovery Center, an expert in this field of the role of the physician in dealing with drug and alcohol treatment. We're going to take a short break, come back, talk a little more. We're going to talk about some of the medications that are available and some of the treatment that Dr. Forrester is using. So, important topic. Please stay with us. We're coming right back to Straight Talk.
Your daughter just had her first breakup. Do you A, put yourself in her shoes? B, console her?
Don't worry, sweetie. This is gonna happen a lot.
Or C, find her a new boyfriend?
Nice, single boys. That was weird.
As a parent, there are no perfect answers. But you don't have to be perfect to be a perfect parent. Thousands of teens in foster care will love you just the same.
It's a short ride from your neighborhood to your naturehood. Find fun activities to do, like boating and biking, or camping and hiking, plus much more. To find a neighborhood park or green space near you, visit discovertheforest.org.
Don't allow your weight to threaten your health or control your future. Excess weight or obesity can cause emotional and physical health risks. But you can take control. The Your Weight Matters campaign offers free resources and tips to help you measure and understand your weight. Take the Your Weight Matters Challenge. The free toolkit prepares you to speak with a healthcare provider about your weight. Your weight does matter. Take the challenge and take control today.
Hi, welcome back to Straight Talk. We're talking about the role of the physician in dealing with our current epidemic, our opiate epidemic, drug problems that are out there, and what we need to know and look for in a drug program and make sure they do have a qualified physician to be there. We're talking with Dr. Alfred Forrester, who is an expert in this field, works as a medical director at the Maryland Addiction Recovery Center, and has many, many years of experience. Dr. Forrester, again, thanks for hanging in there with us.
Thank you.
Again, you're on the front lines, and we've been going through this opiate epidemic for a while. What are you seeing when we talk about the opiate problem, ages that are coming in, how serious, what kind of condition are people in when they're coming into treatment from this epidemic?
Well, we can't really overgeneralize because we see a lot of different things. We see, I think, probably at least two major groups of people coming in who have been opioid users. One group would be people who have had some sort of pain syndrome. It might be post-operative pain, it might be post-traumatic, and they may be started on opioid medications by their physician. And after a while, the physician may decide, well, he's been on this medicine for too long, and so he just stops the medicine cold. Or he may continue to prescribe medication, but the patient may find that the medication is very expensive. He has very high copays through his insurance. And so little by little, patients will find their way to people on the streets who are able to sell them things, opioid tablets or heroin, and they may get converted over to, becoming a substance user in that way. There are also those individuals who use these substances to get high, and this may be a different group of patients entirely. They don't have any pain syndromes, they're really interested in a quick high, and the drug just sort of absorbs them into its network.
Takes over their life. And then when you add in the synthetic fentanyl that is now part of it, it becomes kind of a Russian roulette for a lot of these people. So you could be a nice middle-class man who just had surgery, and a few months later you're out on the streets and you get fentanyl.
Right.
And you could die very easily from it.
That's right.
It's amazing to hear these stories, that are going on, and it's hitting all communities. It just doesn't discriminate. It's happening to everybody.
But the other interesting point that we sometimes forget is we talk about patients who have an opioid use disorder. However, most of the patients whom we see have been using multiple substances, and so it's really not that they're coming in with an opioid problem. They may be using marijuana and cocaine and amphetamine and alcohol, and they may be using all of them at the same time, or they may have switched from one to another. But when you take history, you find that there's been a progression. They may have started using marijuana and alcohol as a teenager, and then they sort of progress to other substances. And when we see them, they may be using 5 or 6 different things at the same time.
Yeah, I mean, you've heard the word gateway drugs,
Right.
whether it's mental, physical, or just part of the social world. I guess when you're into doing drugs, you're into doing drugs. And as you described earlier, if you're using it to cover up pain or whatever's going on in your life, you're going to probably look for something to get you a little higher.
Yes.
All the time. When you put someone on medication for either an opiate disorder or a mental health disorder, how do you balance that out with someone who comes in? We're going to talk about some of the new medications.
Right.
But I'm curious, when a patient comes in and you have to make those decisions of what medications they need to be on.
Well, we have to deal with the most serious sort of issues first. And so in some centers, and this isn't usually the case in our center, but in some centers you may have people coming in off the street. They've last used heroin maybe 6 to 12 hours ago. They're having acute withdrawal symptoms, and if we are taking them into our program, then we're going to need to medicate them in order for their symptoms to be relieved, and that they can be then hopefully taken down gradually by use of a medication that will stop the process of withdrawal and be able to allow them to function halfway decently. So if someone comes in such a state, in acute withdrawal, we may start them on a medication such as buprenorphine, which is used frequently as a medication that will take the place of the opioid, and then over a period of, usually weeks to maybe months, we'll be able to taper that medication and get them off of it in many cases. So we have to deal with the emergency sort of issues first. When we're sort of past the acute crisis, then we can take more detailed history from that person. And if that person has an untreated depressive illness, or if they have attention deficit disorder, which has never been recognized before, then we will probably institute treatment of these other conditions at the same time in the context of the treatment program in which the patient is being treated. Many patients, however, those that I see currently in our center, have already gone through a detox protocol and a rehabilitation someplace else. And when they come to us, they may have been abstinent of substances for maybe a month or two. And at that point, we're in a much better position to be able, from day one, to decide what needs to be done in terms of dealing with their psychiatric or their medical conditions.
But that process, as you say, when they first come in off the streets, which many of them do, they need to physically deal with the detoxification.
Yes.
And that may take some medicine too.
Right.
To help them. And then they go into the next phase. So when you get to the point where you can really get to the root cause, whether it's depression or some other things going on, then you can also treat that.
Right.
But if somebody's coming in off the street, you need to deal with, as you say, the crisis of just using heroin a few hours ago.
For sure, yes.
And so that medicine's there. When people are out looking for a program, there's a lot going on now about a lot of new drug programs opening up, and people are worried, is it a good program, a bad program? It seems so obvious from what you're saying that every program needs psychiatrists, physicians to be there with the drug and alcohol counselors to work as a team. Is that correct?
Yes, I think that's very correct.
Now, if somebody's looking for a program, they should make sure that's there.
Definitely. I think, in the same way that hospitals are credentialed by certain agencies and they're certified, in the same way that physicians have residency training and they become board certified by specialty boards, in the same way that social workers have certification boards and psychologists, these treatment programs need to go through that same sort of process. And so there are certifying boards that will do very stringent examination of the facility, will review the
staff,
individuals.
And the staff.
And that's right.
Excellent.
And so that's very important.
Good, good, good. We got one more segment and want to talk about medications for this opiate epidemic. So hang in there. Appreciate you being here. We're talking with Dr. Alfred Forrester, expert in the field, physician, helping people get off of drugs. That's what it's all about. So stay with us. We're coming right back to Straight Talk.
I just need a second.
Is your weight holding you back? Are everyday tasks getting harder and harder to do?
Did you see this?
Hmm?
Your cousin's in the hospital from a heart attack.
Really?
Health risks associated with excess weight or obesity can be serious. But you can do something about it.
I know you're worried. I found this.
Take the Your Weight Matters Challenge. Visit yourweightmatters.org, where you'll find free resources to help you take control. You can start improving your life right away. Download the free toolkit to prepare you to speak with a healthcare provider about your weight and health. Your weight does matter. Accept the challenge and take charge today. Visit yourweightmatters.org.
I had big plans. I had my career path all planned out. While I was on a combat patrol in Baqaba, Iraq, a rocket-propelled grenade took my arm off at the shoulder. When I came home, I felt alone. My family was around me, but I couldn't talk to them about what I'd seen and what I'd done. I remember just thinking, man, the way I am right now, I don't want to live. I was discharged from the Army, and I've been working with the Wounded Warrior Project since 2007. Warriors don't have to be severely wounded to be with the Wounded Warrior Project. We do have a lot of guys that have post-traumatic stress disorder. Being able to share your story, I guess it kind of helps you wrap your mind around what did happen over there. Just because you left the military doesn't mean your life is over. Because when these guys are coming home, I'm kind of leading and training them. Instead of for combat, I'm leading and training them to heal. If I come away with anything from Wounded Warrior Project, it's them giving my life back. My name is Norby, and yes, I do suffer from post-traumatic stress disorder, but I'm okay.
Hi, welcome back to Straight Talk. We're talking with Dr. Alfred Forrester, who is an expert, a physician working with addiction, working as the medical director at the Maryland Addiction Recovery Center, but teaching us about what we should be looking for if we're looking at a drug and alcohol treatment center to make sure they do have a physician, a psychiatrist, someone there to help with the medical side of addiction. And part of that is the medications. Dr. Forrester, thanks for hanging in there with us.
Oh, thank you.
Let's talk some about these new medicines. You know, for years and years, most people, when you heard about heroin addiction, they went on a methadone program.
Right.
You had already mentioned before about buprenorphine.
Right.
But there's more. What are these drugs doing? What do they, how do they help? How do they not help? And how long should people be on them? Let's talk a little bit about these medications that are out there.
Well, there are certain medications that we may use when someone is coming into a program wanting to get off of heroin, let's say, or other opioids. There are medications that we can use to make the switch over from the street drug to something that's going to be safe. We know that it is not going to be tainted with other contaminants. We know that it's going to, over a period of time, be tapered so that hopefully someone will be able to be entirely abstinent of that substance. And so we have a number of agents. You mentioned methadone. Methadone has been in use for quite a number of years, but a relative newcomer has been buprenorphine, which has been on the market for probably about 15 to 20 years. And we use it as an agent that will stimulate some of the same receptor sites as opioids that people have been using on the outside. But we use it in combination with another agent, which is called naloxone. And people may have heard of naloxone because there are many centers, pharmacies, public agencies that will make naloxone available to people to deal with overdoses that happen on the streets. So it turns out that naloxone is paired with buprenorphine, and we use that therapeutically as we are tapering someone from, his opioid use to hopefully abstinence. The naloxone, also called Narcan, can be administered by anyone who has a little bit of training with its use, and many lives can be saved by using that, and that's available to the public. But in a treatment program, we'll prescribe the combination of buprenorphine and naloxone. We have other forms of the buprenorphine. The most common form is a sublingual form. It's a film that goes beneath the tongue, or it may be a film that goes on the inside of the oral mucosa in the mouth. But we have now implantable forms of this medication. So buprenorphine can be supplied in a solid rod that's implanted in the arm. And
now, will this stop a person from getting high? Will this, if they get high, if you give them the buprenorphine and then they try to get high, will they get high or not?
Well, if someone is on the combination of buprenorphine and naloxone, which comes by a number of different trade names, if one is using that combination, the naloxone is responsible for really blocking different opioid receptor sites in the brain, so that if someone is going to use a substance on the outside, he's not going to have the effect of that. There's another medication called naloxone that or naltrexone rather, that we also use. Naltrexone can be used actually both to reduce cravings for opioids. It also is used to reduce cravings for alcohol by a different mechanism entirely. But this medication can also be very useful in long-term treatment of individuals who need to have some additional medication support. Naltrexone can also be supplied in a couple of other ways. It can also be supplied as a bar, a solid bar, which gets inserted into the abdomen and can give some benefit to individuals for a couple of months. It can also be given as an injection into the muscle, given once a month. Also to be used to reduce cravings for opioids as well as alcohol.
Now, as a physician, and you're also working on, because you were mentioning like an abstinence kind of a program.
Right.
What's the time frame? Now, methadone, which has been around for many, many years, there are people on methadone for years.
Yes.
These other medications, how do you look at a time frame on something like that?
Well, I think it'd be fair to say that we look at each person on a case-by-case basis. The majority of individuals probably do not want to be on substances for a long period of time, and so we will taper. If someone has been started on buprenorphine, we'll generally taper that person over the course of maybe a month or two. But it really depends on the person's tolerance to the drug, depends on how serious the withdrawal symptoms are when you start tapering the medication. So some patients are going to be slower than others to come off.
Listen, Dr. Forrester, Dr. Alfred Forrester, helping us a great deal today. I really appreciate you being on the show. You're a wealth of information that the public needs, and I think you told them it's important to have a physician, psychiatrist at a treatment center that understands addiction and knows what they're talking about, and you certainly do. And thank you so much for being on the show and sharing your knowledge with us.
Well, thank you very much for having me.
Today on Straight Talk, we were looking again at the opiate epidemic. What do we need to know? Dr. Forrester certainly told us what we need to know when you're sending someone you care about or yourself needs help. You go to a program, it's important to have that good evaluation and have a physician available. So if you have a problem, make that phone call, get help for yourself or someone you care about. And I want to thank all of you for watching Straight Talk, and we will see you next time.